You can start.
Great. Okay, thanks so much. Welcome, everyone. Thank you for joining us for the meeting of the New York City Health and Hospitals Medical and Professional Affairs Committee. Today's meeting is now officially called to order, and I'd like to start by welcoming Dr. Michael McCrae, who is representing Dr. Chinazo Cunningham as a voting member today. So welcome to Dr. McCrae. All right, if I could now, I'd like to make a proposal for adopting the minutes of our meeting, which was September 13th, 2001. Can I get a motion?
So moved.
All right, and second?
Second.
Thank you. All right, let's get a vote then. Jose, do you want to start?
Yes.
And Sally?
Yes.
And Dr. McCrae?
Yes.
All right, and I as well vote yes, so that passes then unanimously. And we could go on now actually to our action item. Dr. Barron, I believe, will be presenting it. That's our coordinated behavioral care resolution. So is Dr. Barron there to present?
Yes, I'm here.
Super. Okay, great. Thank you.
Dr. Barton, can you read the resolution into the record, please?
Yes. Good morning. I'm requesting authorizing the New York City Health and Hospitals Corporation, or the system, to enter into a best interest 5-year renewal agreement with Coordinated Behavioral Care IPA Inc., or CBC, for case management of system patients with persistent behavioral health issues at a cost not to exceed $17,977,600. So, background information on this are that many of our behavioral health patients at health and hospitals are high utilizers of acute care services, but are not often engaged in ongoing ambulatory behavioral health care. A successful transition from psychiatric inpatient and/or emergency department treatment to a community-based setting for adults with serious mental illness requires skilled and intensive care transition services. The New York State Office of Mental Health Medicaid Performance Opportunity Program, or POP, mandates clinical partnerships between payers, healthcare providers, and care management agencies to provide intensive care transition services to manage behavioral health patients with a high acute care utilization. The Office of Mental Health recommends critical time intervention, or CTI, as an evidence-based and time-limited intervention as a model of care. OMH has endorsed and funded a Pathway Home pilot program in CY 2018 to 2019, which was implemented at 2 New York City hospitals, one of which was New York City Health and Hospitals Bellevue, in partnership with the Office of Behavioral Health. Coordinated Behavioral Care, or CBC, is a provider-owned and led nonprofit organization consisting of a Medicaid health home, an independent practice association, IPA, and an innovations hub which develops and incubates new program models such as Pathway Home. Pathway Home's goal is to ensure uninterrupted and coordinated access to behavioral and physical health services while addressing the social determinants of health. CBC acts as a single point of referral to multidisciplinary teams at care management agencies in CBC's broader IPA network. These teams maintain small caseloads and offer flexible interventions where frequency, duration, and intensity is tailored to match the individual's community needs and have the capacity to respond rapidly to crisis. The Pathway Home program meets OMH's recommended CTI model requirements by providing multidisciplinary and high-touch transition services beginning prior to hospital discharge. These services continue into the community for 6 to 9 months after the initial engagement. Pathway Home is the winner of numerous awards, including Crane's Heritage Innovations in Healthcare Delivery Award in 2019, and the Case Management Society of America Case Management Practice Improvements in 2019. So I can't read that far. Health and Hospitals and CBC's partnership. Based on the experience of the OMH pilot at Bellevue, One City Health, a subsidiary of New York City Health and Hospital, entered into a 15-month agreement with CBC beginning in June of 2019 to extend Pathway Home services to 4 additional health and hospital behavioral health services at New York City Health and Hospitals Metropolitan, Harlem, Lincoln, and Coney Island. The agreement was approved by the One City Health Executive Committee and One City's Board of Directors with a not to exceed amount of $4,294,476 funded through the Delivery System Reform Incentive Payment or DSRIP program. This contract was further extended through December 31st, 2021, with H&H funding approved by the Clinical Service Planning Committee. In March of 2021, OMH declared an extension to the POP mandate. With this extension, the Office of Behavioral Health recognized the needs to not only extend the service, but also to expand the service to a larger group of eligible patients from the health and hospitals risk pool. The program will move from hospital-based to a borough-based model, with CBC playing the role of a single point of access for referrals, as well as 24/7 on-call access. If approved, the services will reach POP-eligible health and hospital risk pool members who will be discharged from all 11 New York City Health and Hospital Behavioral Health inpatient services. CBC will be expected to enroll at least 90 to 100 patients per team per year. Under the operating procedure 100-05, the system can renew a contract with appropriate vendors and pricing due diligence rather than reprocure when it is the system's best interest to do so. CBC and Pathway Home teams have provided significant value to health and hospitals, patients, and inpatients clinical teams in transforming high-risk patients into the community and engaging them into outpatient clinical services, as well as community-based support services. Since CBC's IPA network itself consists of 50 community-based organizations, both the staff, 85%, and the board, 75%, are composed of minorities and or women. There are no competitors in New York's downstate catchment area who provide similar services. Initiating an RFP or a new service provider would require undoing the work done over the past 3 years and would present serious service gaps for this vulnerable patient population. To meet these goals, the Office of Behavioral Health is requesting a best interest renewal of the current agreement for the period January 1st, 2022 through December 2026, with a not to exceed amount of $17,977,600. The pricing for the proposed best interest renewal has no increase in unit cost. Health and Hospitals funding supported by DSRIP earnings was approved for the best interest renewal by both H&H Clinical Services Planning Committee and the Contract Renewal Committee. In looking at the cost details, the cost per team per year is $898,880. That means $832.30 per enrolled patient per month, approximately $9,987.60 annualized. This represents the cost for 90 to 100 patients per team per year. 73% of the cost is dedicated to salaries for the multidisciplinary care team. Each team consists of 1.0 team leader, 1 RN, 2 senior mental health clinicians, 2 case managers, 2 peers, and 0.2 contract manager. Cost for the 4 years per team is $3,595,520, and the total cost for 4 teams for 5 years is $17,977,600. To review the accomplishments of at H&H by CBC, they have enrolled 689 unique patients receiving Pathway Home services between February of 2019 and June 2021. The patient engagement rate is 68%. Of the 689 unique patients, with looking at the 30-day follow-up after hospitalization, which is a HEDIS and a value-based purchasing metric, the rate is 81%. This compares with the system-wide comparison prior to this of 47.4%. Our reconnection to primary care and specialty services post-discharge with Pathway Home is 90%. Connection to long. Excuse me? Connection to long-term care, community-based coordination services such as health homes, that's 56%. Significant differences in the emergency department and inpatient visits between program participants when compared to the control group. The CTA group in the retrospective cohort design study averaged 5.3 visits within 9 months post-program enrollment, while the control group averaged 10.5 visits during the same look-back period. Similar findings have been reported in other published studies by PH. A recent CBC study, a population of health members, non-H&H, this is a non-H group, using Medicaid Psyches data, indicated a net savings of $41,296 per member over the course of an 18-month program participation. If this rate is applied to the current 5-year renewal request, this would represent $55 million in savings, or a return on investment of $37 million. An overview of Pathway Home program, its distinguishing features by beginning engagement before discharge from an acute care setting, such as an ED or a CPAP visit or a hospital admission. The team-based model will provide high-risk patient populations with support with the community to connect with outpatient clinical services as well as social services. Pathway Home team members meet with patients at least once a week for the first 3 months, accompanying them on the day of discharge and to their subsequent mental health, substance use disorder, and primary care clinic appointments. Visit frequency is always based on patient needs. This intensive care management model aims to strengthen community-based care through development of individualized longitudinal care plans, as well as a focus on skill building. Program goals are to strengthen community-based care and improve connection to outpatient services post-discharge, to reduce avoidable readmissions and emergency department use, to shorten the length of stay, to increase enrollment in health home care coordination to maintain ongoing case management post-intervention, and to increase medication adherence through medication management and reconciliation. So again, the resolution is that New York City Health and Hospitals Corporation, the system be and it hereby is authorized to, do I read this? No, never mind. Is there any questions, comments?
Let me actually individually ask each of you if there are comments. So Jose, perhaps you can start. Any questions or comments?
No questions, just to comment that the fact that this is a program that begins before discharge and how you make a clearly compelling case that this will improve the care of our patients and lead to some financial savings that would allow us to provide more care to patients is great. Thank you.
Thank you. Sally Hernandez-Pinheiro, any questions
Yeah,
or comments?
I have a number of questions, and it's just because I don't know much about the program. So if I may, the partnerships are between payers, healthcare providers, and care management agencies. So in this situation, who are the payers, the healthcare providers, and care management agencies? Which entities?
At this point in time, we're proposing that Health and Hospitals will become the payer to CBC, which is a collection of community-based organizations. They will be providing the services to the patients They are the community-based organizations providing the services to the patients for health and hospitals.
And they also do the care management then?
Yes, the interventions that they provide are the care management services, correct?
Okay, and then the entity has 3 entities within it. Oh gosh, now I can't find it. Oh yeah, it has an IPA, an innovations hub, which I don't guess is involved in this, and a Medicaid health home. Is that part of this as well, or?
The CBC is a umbrella organization that has those 3 components.
Right.
Yes.
But are all 3 components involved in the provision of care here?
Indirectly, yes. As I said, they are made up of 50 community-based organizations that make up the IPA.
Okay.
As well as an innovations hub to try out new evidence-based practices. So yes, indirectly they are providing all that. But the evidence-based practice is the Pathway Home CTI model.
And the cost is about $18 million, and they're going to treat about 100 patients, you said. So that's about 100
each team. It'll treat
team.
about, yes.
And how many teams are there?
4.
So it's 400 patients, $18 million.
400 patients each year for 5 years, correct.
And there always seems to be so much difficulty in placing very troubled mental health patients in homes, in facilities that are for longer term, because here they're going to work for a certain period of time with the patients. Are the patients then placed in a facility where they'll be for some time, or how long does that arrangement last?
The formal part of Pathway Home intervention, the critical time intervention program generally lasts for 6 to 9 months. So from the time of discharge from one of Health and Hospital's inpatient services, they will be working intensely with the patient for 6 to 9 months to engage them in treatment. If they don't have housing, they will be working on getting them stable housing arrangements, whatever their psychosocial and medical needs are. If at the end of 9 months they feel that the patient is still unstable, they would continue to work with them. The idea is once 9 months is arrived at, basically they would be stable enough to be transitioned to a slightly lower level of care management in our health home.
It's more
They would not be like completely let go and not be followed, but they would be transitioned from the Pathway Home program to another care management, lower level care management program. Yes.
But they're not placed in a facility. They're just aided in managing their issues and transitioning to a more stable life, but they're not going somewhere specific, right?
They may be going somewhere specific. Part of it depends on the patient need. Say if I said they were homeless or unstably housed, then the program would work with that patient to get them housing or more stable housing.
Yeah.
If they needed a more intensive level of say residential services, they would work with them to get them to that program and engaged in that program and going to that program.
Yeah, unfortunately, securing housing is almost an impossibility in the city, but how are the patients selected?
There's a criteria established by the state. Anyone who has had 4 either psychiatric admissions or emergency department visits, whether that be psych or medical, within a year's period of time is eligible for this POP program that would be automatic to CBC from us. The facilities are also free to make other referrals if they feel someone is like on the verge of potentially having that fourth admission. They can also make the referral. They're not excluding those.
Okay, I don't follow your savings model because you're spending for 400 patients about 24 times about $50,000, and I don't get. I just can't follow your net savings.
This was basically a projection that CBC did a study with a similar population to our health and hospitals, Medicaid or uninsured population. And so they began with and found that they were saving an average of $41,000, et cetera, per patient for about 18-month period of time. If we applied that, this is what we would say that once you took out the $18 million, that we would potentially save about $37 million. But this is a projection. This is a projection based on something.
Yeah, I'd like to follow up on how you calculate that, but I don't want to take time now.
I'm happy to give you very detailed. I'm happy to do that.
I have no basis. It seems expensive, but what you're doing is important. So I'm done.
It is expensive, yes. But okay, I'll happy follow up with you. Sure.
Okay.
Good morning, it's Barbara Lowell. Thank you, Sally. That was wonderful.
Thank you.
I just want to commend the group that worked to put in place this array of services for healing the healers. I know some people personally who have had difficulty during this time and had difficulty finding the help they really needed. So thank you. This is remarkable, and all the details I'm sure will be worked out.
Thanks, Barbara, for those comments. And Dr. McCray, did you have any questions or comments?
No questions, no comments.
Thanks so much. I just have a couple of quick comments. One is that this has been ongoing for a while, so we have an IPA that's been providing services. And I guess the question then is, have we kind of looked at the individual participants to have a comfort that their success rates and so on are as good as others? In other words, have we kind of weeded out if there are some that are not providing care as well, and in fact, increased the use of those who really have good outcomes? So I'm just curious if we've had that ability to hone in that deeply and sort of again examine the performance of the members of the IPA.
There are at present there are 4 different community-based organizations of the IPA that are teams. Each of the teams is a different CBO. We have looked at each one of those, and their success rate has been really quite good. All of them, yes. So we are monitoring each of the different teams, each of the different organizations to see that they're performing up to what we expect. And so far, during this pilot phase, they have been doing really an exceptional job.
Yeah, it's super to see some of the relatively short-term and intermediate-term results already. And I think this is very worthy certainly of looking at long-term, and hopefully we're keeping statistics and can look at that, because
Yes.
it really is a great program, and I applaud the work you guys are doing. So with that, any other questions? Otherwise, I'll go to a vote.
Actually, I do have one question. This is Michael McCray.
Sure.
I'm just wondering, what are the specific qualifications for the case managers or experiences?
The team members, well, the case managers are generally people that have done case management. They also, everyone goes through a standard training program that is done by the state. The critical time intervention has its own training program that the state and combined with CBC gives to everyone that participates in the team. And the team is made up of a team leader and RN who supervise all the case management services.
Thank you.
Okay, if no other questions, let me put to a vote then. Dr. Pagan,
Yes.
Sally Hernandez Pinheiro,
Yes.
Barbara Lowe. Barbara?
Yes.
Thank you.
Yes.
Thanks. And Dr. McCrae?
Yes.
I'm yes as well. So the motion passes unanimously. Again, thanks for that excellent presentation and the great questions that were asked. So if we can, then let's move on actually to our reports. Dr. Barron, actually, I think you're giving the Chief Medical Officer report.
Yes, thank you. The report for Dr. Allen primarily has just an extension of last time. I will go over some highlights. There is one follow-up item. I believe it was Ms. Lowe that asked about our esketamine protocol. Basically, Health and Hospitals has not yet started to use esketamine. We are preparing for this. We've had many meetings with people, the experts using esketamine for retractable depression. We have been developing the appropriate protocols for use, and in the process of being added to our formulary system. Esketamine is approved for use in treatment-resistant and severe depression. It's administered in a clinical setting under supervision and monitoring, and it has been shown to be very highly effective in the treatment of severe resistant depression. So we are planning on using that. I believe you commented that the FDNY uses esketamine in the field for sedation, for delirium and other things. And we did confirm that, yes, they are using this, and they have a protocol for using this, but ours will be used primarily for treatment-resistant depression, which the FDA has made approval for. Other highlights of the CMO report is basically behavioral health is continuing to standardize and optimize ambulatory behavioral health services in order to increase our access for services. We've been optimizing the use of Epic and other electronic modalities to streamline and making appointments, increasing utilization and tracking data availability for more efficient analyzation. In our child and adolescent programs, our post-COVID services and DOE collaborations to bring additional support to students in the neighborhoods most impacted by COVID-19 pandemic. We're collaborating with the Mayor's Office of Community Mental Health and the Department of Education to structure a new partnership between the city's public hospitals and over 25 public schools. This partnership, called Pathways to Care, expedites referrals from schools to connect students to care to our outpatient mental health clinics. The program rolled out in November of 2020. We currently have 4 clinics participating: Kings County, Woodhull, Gouverneur, and Elmhurst. And we're in the process of onboarding 5 mental health service corps members to add to 5 clinics at Harlem, Woodhull, Morrisania, Lincoln, and East New York. And we'll be working with these clinics to continue to expand this program this fall. The Behavioral Health Emergency Assistance Response Division, or BHERD, is a new health-centered response to 911 mental health calls. This began in June 6th of 21, covering East Harlem and parts of Central and North Harlem. In the areas where BHERD operates, 911 call operators dispatch new BHERD teams, which consist of the FDNY emergency medical technicians and social workers from the New York City Health and Hospitals as first responders to people who experience a mental health emergency. And these instances do not involve a weapon or imminent risk of violence. The BHERD teams use their physical and mental health expertise and experience in crisis response to de-escalate emergencies and provide immediate care. To date, our social workers have provided engagement and assessment for 269 individuals. Of the outcomes of the 269, 41% were transported to the hospital for further evaluation. 57% were treated in place and accepted referrals for aftercare, and 2% were treated in place and refused a referral. We do plan to expand to another precinct in the northern Manhattan area, and eventually to some of the other areas that have high-risk individuals. And I believe the rest of the report, basically, I'll leave to the committee. They are the same. We do, again, have expanded our house staff wellness programs, with continued to have increased referrals for there and referrals, and have a multi-access for people. We have a concierge line for people to call, as well as websites and other mechanisms to make sure that our house staff and our staff have referral for wellness support during this crisis period of time. And that concludes my report.
Thank you. Any questions, Jose, Dr. Pecan,
No, thank you.
and Sally?
Just a quick question. On your students program, how many students have been referred in the approximately 1 year period since it started?
I believe I'll have to get back to you on that.
Okay. Do we have any programs where young people can directly go for mental health services? Because this is a school referral, right? It's not young people contacting you directly.
The young people can go, we do have basically walk-in services for children and minors. We of course have to have some involvement of parents, except for certain circumstances. But they can refer themselves, yes.
Okay, thank you.
Even in this program, they can refer themselves. We have it set up so at the school, there's someone that they can say, I would like to talk to someone or be with someone, and they would be directly referred, yes.
All right, thank you.
Thank you. Barbara Lowe, any questions or comments?
Yeah, I just want to thank Dr. Barron for that follow-up on the ketamine. I hope that in the training they utilize the one legal case that's ongoing for the adolescent who was given ketamine and then died subsequently. And so that was one of the clinical things that caught my attention, and it may be a good case review for people to discern who can be considered for ketamine treatment in a crisis mode. Thank you.
Thanks for that comment, Barbara. Dr. McCray, any comments, questions?
No questions, no comments.
Thank you. All right, then we can move on actually to the Chief Nurse Executive Report, Dr. Sinea.
Good morning. In observance with the National Hispanic American Heritage Month, the Office of Patient-Centered Care held an educational and virtual dance event. Frontline staff and various host leaders attended via WebEx. The event was led by instructor Marlon Mills, who is one of New York's most well-known dance personalities in the salsa dance community. This past month, we also have launched a CUNY partnership. This partnership is actually an expansion of our current partnership that focuses on 4 pillars, focusing on career development. This partnership will allow us to develop and enhance our on-the-ground clinical skills building capacity, to provide professional nursing workforce development, nursing research and evidence-based practice, and to establish the first time ever a health equity policy forum where frontline staff and nurse leaders will participate to really focus on population health and social determinants of health. In September, we also launched a nurse leader work group. The nurse leader work group will entail opportunities for nurse leaders to really revamp our orientation, to establish a nurse leader academy to strengthen the leadership skills of incumbent leaders, to assess and to create nurse leader annual competencies, to focus on nurse leader diversity, equity, and access opportunities, to focus on nurse leader continuing education, nurse leader mentorship and succession planning, and to revise our current nurse leader job descriptions, and to look at diversity and recruitment. Within our culture of safety pillar at the Office of Patient-Centered Care, we're very proud to announce that we recently launched our Behavioral Health Associates Academy in partnership with the Behavioral Health Department. to train our staff on de-escalation. We've also recently finalized an educational module named Agitated Patients to also learn how to de-escalate patients who may be agitated. We most recently also launched a search engine for knowledge named EBSCO to ensure that our frontline staff have the access to the latest evidence within nursing. We also launched a stroke standardized curriculum, and we've also launched a repository of knowledge named Elsevier for the emergency department and post-anesthesia nurses to ensure that they also have evidence-based practice resources. We have also launched the American Heart Association RQI Digital Resuscitation Program, which is a paradigm shift in delivering digital resuscitation program, going from the instructor-led model to a more digital model to ensure a rigorous program. And this will be available to our physicians and nursing staff. We've also implemented a COVID vaccination protocol, and we've rolled out the booster shot education for our staff for patients ages 8 and older. From a quality perspective, the Office of Patient-Centered Care is in the process of laying the foundation for the creation of a system-level nursing quality council and to establish nursing quality dashboards to ensure that we are also implementing frontline staff with the education and the evidence-based practice needed to reduce nurse-sensitive indicators with a focus of falls starting January 2022. Our nurse clinical ladder continues to be successful. We've approved 1,961 nurses to participate in the clinical ladder. We've most recently also laid the foundation to create what we call the Positive Practice Quality Research System Team Committee. And this PQRST committee will ensure that we are looking at nursing excellence applications throughout the entire system, looking at pathways to excellence designations and magnet designations. We are also ensuring that all of our critical care sites are applying for Beacon, which is the designation for critical care excellence across the system. I also want to highlight, we've established the opportunity for all of our nurses who are interested in obtaining a doctoral program, that they are supported with a scientific review committee in partnership with MNPA. A few more highlights. We recently launched the social work shared governance implementation, which we're very excited about, ensuring that frontline staff for social work are also empowered to change their practice. We've done a lot of work around the social work scope of practice and role refinement activities focusing on women's health, ambulatory care, behavioral health specialty programs, post-acute and community care. We've also revised the Social Work Directors Council Charter to ensure that we're looking at recruitment and retention of our social workers, staff recognition, wellness, professional training and development, equity and access, and social work student affairs. Within our care experience pillar, we continue to disseminate our work. We recently shared over 20 abstracts and presentations at the New York Organization of Nurse Executive and Leaders Conference. Our professional shared governance for nursing continues to remain strong with our next retreat in February 9th, 2022, where we have over 186 shared governance councils. Our nurse residency program also continues to be successful, most recently expanding it to corrections and community and ensuring that our new nurses' voices are heard. We've seen 100% retainment of all of our new nurses within the nurse residency program. Last but not least, I want to share that we are expanding the RN mentorship program where retirees are coming to train our new nurses. And we've seen 2 retirees most recently come back at Bellevue and Coney Island, where they are mentoring 10 incumbent RNs in the program. Thank you very much.
Thank you. It's a really great and exciting report. Let me ask for comments. Dr. Pagan, any questions, comments?
Just to say that it's nice to hear that you're sharing the knowledge that you're having and you're providing resources for nurses so that they can do wide evidence-based care. Thank you so much.
Thank you.
Thank you. Sally Hernandez-Pineda
No, great report. Thank you.
and Barbara Lowe.
Of course, I have glowing comments. I think that these activities lead to empowerment and therefore lead to very good leadership for the nursing division and all of its employees and better care. Thank you.
I certainly second that, Barbara. Sorry, I got lost there for a second. Dr. McCray,
No, great
any
presentation.
questions, comments?
No questions, no comments.
Thank you. All right, let's move on then lastly to the Metro Plus report. Dr. Schwartz.
Thank you. Good morning. I'll start with a few regulatory highlights in terms of COVID-19. The moratorium that has been in place now for about 1.5 years on disenrollment of government-sponsored members has been extended again. The moratorium will be now in place at least through January of 2022. That means that all of our members who are sponsored by government coverage do not have to provide proof of eligibility. We do expect that that moratorium will ultimately expire early next year, and we have been preparing for this for a while at this point. There are a couple of federal laws that are impacting our industry significantly and the population significantly. I think we all know or heard of stories where the commercial population has been charged with significant out-of-pocket expenses, even though they are covered. There are 2 federal rules that are going into effect: Transparency and Coverage Act and No Surprise Act, essentially mandating the health plans to provide tools to the commercial populations so that members can check what their out-of-pocket is going to be, compare what the out-of-pocket might be between different providers, and then make an informed decision. For our lines of business, that will impact QHP and Gold lines of business. That actually is in addition to an interoperability law that just went into effect July of this year. And this interoperability law requires health plans to exchange information between themselves. What has been happening, I'm sure you all experienced this, if you switch one coverage from one plan to another, essentially your history is lost. And you need to restart, right, the story, and sometimes all of the studies that you have and all of your medical information. With the interoperability law that is now in effect and we're compliant with, the health plans are mandated to exchange information with a look back of 5 years, so that if a member is switching coverage for whatever reason, their information is available and goes with them. Moving on to membership. At this point, our membership is close to 640,000 members. We grew over 22% since the beginning of the pandemic. The government-sponsored programs are doing well. We saw some losses in the commercial lines of business, specifically in QHP, because of rates. This will be course corrected in 2022. And MLTC due to carve out of long-term nursing home members back into the state. I think the committee is aware that we transitioned behavioral health services from Beacon Health Options back into Metro Plus. Now Metro Plus is providing network solution for behavioral health contracting, care management, utilization management, customer service, appeals, and really all of the functions that are related to behavioral health in a health plan. I'm happy to report that that transition went very smoothly without any major hiccups. In terms of clinical approach for the BH transition, we have a variety of behavioral health clinicians now on board. We are continuing to recruit as our volume increases, and when we're fully staffed, we'll have approximately 75 individuals with different behavioral health licenses supporting our members. We have essentially the same number of support employees who are not clinical to administer the BH services. To deliver on our promise of better coordination between physical and behavioral health services, our teams are using the exact same platform, both for physical and BH. So at a minimum, and obviously it's a starting point, not an ending point, everybody has a 360 view of the patient needs from all of the perspectives that the patient might have, not BH separately and physical health separately. In terms of transition from Beacon, when the transition happened, approximately 4,000 members were in active engagement and case management with Beacon. Those 4,000 members were transitioned now into our team. They were stratified, and obviously the most acute members were worked with first to make sure that nothing falls through the cracks and members continue to receive the support services that they need through care management. In terms of BH network, there is a requirement in terms of continuity of care and consistency of care, where the requirement is that MetroPlus would have at least 90% of the same network as the network that was available through Beacon. We were able to contract and credential 95% of the network that Beacon has, so there is very, very little disruption. For the 5%, we are approving 6-month transition period. So for the 5% who are not currently in our network, but members are still receiving treatment, they will remain in their treatment for 6 months, and they will either complete their treatment in that period of time, and if they need ongoing treatment, our care management teams will work on transitioning them to an in-network provider over the course of the 6 months. And then at this point, four weeks in, we're addressing all of the phone calls appropriately, meeting all of the SLAs. At this point, we already got 10,000 BH claims and processing and paying for them so far without hiccups. This quarter is really focused on stabilizing the operation just to make sure that the basics are working. The more enhanced and more aspirational parts of better collaboration, more alignment with the provider community will start early in 2022. And then just to inform the committee about the foster care program that went live July of this year. Foster care transitioned from the state to managed care. We're talking about the voluntary foster care agencies. There are approximately 9,300 kids in voluntary foster care agencies statewide. We received 11% of the state volume, which is slightly over 1,000 kids. In terms of the responsibilities that we have with us children, specifically it's coordinating PCP assignments if they don't have a PCP, making sure they have access to care, making sure that the mandated health assessments are completed, they get DME if they need any, that they receive referrals to any specialties, assistance with court order services, fair hearings, and then following up on gaps in care and making sure that any kind of care management intervention is available to those kids, obviously with much more significant needs than kids outside of the foster care agency, foster care system. We are contracted with 34 different agencies. This was a pretty significant transition for the agencies who have never worked with managed care. They suddenly need to submit claims and they need to kind of figure out the managed care system. I have to say there was concern around this transition. A lot of the foster care agencies do not have a lot of cash on hand, and so there was a concern with this transition just as they learn the ropes. But we had 3 years to get ready for it, and so we have done a lot of education with the agencies, and the transition went smoothly. We're obviously very proud of the centers of excellence that H&H has as it relates to foster care children. And anytime that a child comes to us through the foster care system who does not have a PCP, we assign them to the centers of excellence at H&H. And that completes my report.
Thank you very much. Comments, questions, Dr. Pagan, any?
No questions, thank you.
Dr. Katz?
No, thank you.
And Sally Hernandez-Pinheiro?
I just want to take a moment to acknowledge the extraordinary amount of work that Dr. Schwartz and her staff put in the creation of this network. The last couple of months, they've been working round the clock weekends because they have a degree of professionalism and quality of care that they aspire to, and they don't want to compromise on. So they didn't cut corners in any way. I also want to thank Dr. Barron for the support he's provided and continues to provide us.
Thank you, Sally, for that. I appreciate that greatly. Barbara Lowe, any questions, comments?
Yes. Oh, it's Barbara Lowe.
Any
With
questions,
regard to the
comments?
foster, I don't know if anyone can hear me, but anyway.
Yes.
Now we
Okay.
can. Go ahead.
Okay, with the foster care program, I think that there's a subgroup of children who've witnessed such horrific events and been subjected to violence also. If there could be some case finding just to find out what's happened with the siblings who witnessed, fatality in their homes. And there's such a large cadre within the foster care system, very much like that. And of course, the mothers are always the case. The case is open for mothers who may not have been victims but are treated poorly. So it's like a family-oriented approach as well.
Absolutely agree.
Thank you.
Thank you for the comment. And Dr. McRae, any comments, questions?
No questions, no comments.
All right, thank you. Any old business or new business for the committee? Right, there being none, meeting is hereby adjourned. Thank you all for coming. Appreciate it.
Great meeting. Thank you.
Thank you.
Thank you.
Thank you.
You all.
Have a great morning, everyone. Be well.
Yes, be well.